Our specific learning objective for the session is definition of chronic stable angina. So angina pectoris is a symptom complex precipitated by transient myocardial ischemia, constituting a clinical syndrome rather than a distinct entity. It is due to an imbalance between oxygen supply and demand. The balance is disturbed. So, coronary atheroma, as we know, is the predominant cause of coronary artery disease and so angina. Although the symptom may manifest in other cardiac conditions like aortic valve disease and hypertrophic cardiomyopathy, they can also produce angina. This clinical presentation underscores the importance of identifying underlying etiologies. So there is a discomfort in the chest, jaw, shoulder, back, or arm, typically aggravated by exertion or emotional stress, and may be relieved by nitroglycerin, but not definitely, because nitroglycerin can relieve esophageal spasm as well. It is commonly associated with coronary artery disease involving more than or equal to one large epicardial artery, and it may also manifest in valvular heart disease, hypertrophic cardiomyopathy, uncontrolled hypertension, and there may be normal coronaries with myocardial ischemia due to spasm or endothelial dysfunction. So what does the category of angina tell us? There is a typical angina, there is atypical angina, and there is a non-cardiac chest pain. A typical angina has three components, all of them. Definite angina and substernal chest discomfort with characteristic quality and duration, provoked by exertion or emotional stress, second criteria, and third, relieved by rest, or maybe nitroglycerin. Atypical angina meets two of the above criteria, and non-cardiac chest pain meets less than or equal to one of the typical anginal criteria as from Diamond classification. So, a mismatch between oxygen demand and oxygen supply is angina at cardiac level. So, if there is more heart rate, if there is more blood pressure, if there is more myocardial contractility, if there is more ventricular wall thickness or LV hypertrophy, and if there is obstruction like aortic stenosis, aortic regurgitation, or hypertrophic cardiomyopathy, there may be increased oxygen demand. And there is oxygen supply decrease in decreased coronary blood flow due to atherosclerosis, shorter duration of diastole, in tachycardias and coronary vasomotor tone in spasms and coronary perfusion pressure changes, low oxygenation at blood levels or at hemoglobin level. All of these will lead to low oxygen supply, and all of us know already from our physiology that coronary blood flow mainly occurs in diastole. So if diastole is shortened, oxygen supply to the heart and through the coronaries is shortened. So next SLO will be addressed in the next lecture with clinical signs and symptoms and lab findings of stable angina.